All right. So we are going strong. We're in our final few hours, I think 8 hours or so of the 24-hour course. Nikesh Shah, a dear friend of mine from India, has been a pioneer, one of the pioneers for foot and ankle in India, amongst some of the panelists that you're going to talk to today. And they're going to give you some insight for what they're seeing on the India side. So Nikesh, take it
Yes,
away.
sir. So, good evening, all. Our topic is given to us is anchors of success: the role of fixation devices in ankle fusion. Fixation options explored and in-depth analysis of fusion rate and patient outcomes. I will introduce my speakers. We have Dr. Sampath Dumbre Patil, who will be speaking on screws and plates. Dr. Rahul Upadhyay will be speaking on TTC nail. Dr. Rajesh Simon will be speaking on arthroscopic fusion. Dr. Malhar Dave will speak on external fixator, and then we'll sum up the session and discussion and question answers will be taken. So I will introduce my first speaker, Dr. Sampath Dumbre Patil. He is Director, Department of Orthopaedics, Sayadri Hospital, Hadapsar, Pune. He is also ex-president of Indian Foot and Ankle Society and ex-council member of Ear Trauma India. He is ex-committee member of IU and Maharashtra Orthopedic Association and also associate editor of BMC Musculoskeletal Journal. He will be speaking on role of screws and plates in the fixation of ankle arthrodesis. Over to you, Sampath. You can share your screen.
Sure. Thank you, Mukesh. I'll be talking on ankle fusion with screws and plates. So, like any other orthodesis, ankle orthodesis will have success if we choose proper approach to prepare the joint and give a good position of the joint, and then, of course, fixation. We we choose anterior approach to have exposure of the ankle plafond and teres, which will allow you to prepare the joint surfaces nicely, as in this case where we did take anterior approach and used 3 screws to have good apposition of the joint surfaces. And this is how he went on to heal. Another case of a trauma, which is delayed trauma, and we decided to go for fusion. In this case, uh, medial and lateral both approaches were taken, transmalleolar approaches, and joint was prepared, and 3 screws were used. And this is how he went on to have sound fusion. This is he is walking painless on this sound fusion. Here we use 3 screws. Now, any approach should give you good preparation of the joint, and good preparation of the joint will give you good position of the joint and good apposition. So here, meticulous preparation of the joint was done, and 2 screws were used to give a good apposition. All of us we know about the position of fusion, and the success lies in the position of fusion. Look at this case; it was not fixed in a plantigrade foot. Equinus was persistent there, and of course she does not like this. So good outputs of the fusion is also in the good position of the fusion. Fixation, we do use screws, 2 or 3. In this case, we have used 3 screws along with the fibula as an autograft, and this is how he went on to heal a good fusion. Now, what literature talks about um, the screws. This particular paper talks about um, the screws with heads have little more complications than the headless screws and differential pitch screws. So we have to consider as a clinician this research. Also, if we are using 3 screws, amount of Taylor surface at the fusion site, how much it is compromised. That is been studied. If 3 or 2 screws, of course 3 screws will take away little more joint surface area. Hence, we may consider applying a plate anteriorly. Here is a case of ankle arthritis with deformity and lateral callosity. We have used only 2 screws anterior approach to have a good fusion, and that is how she walks on it. One few more cases where we have used, this was done by arthroscopic, but 3 screws were used, and this is how a sound fusion was achieved. After fusion, uh, we do give rocker bottom shoes so that gait is improved. When we look at the literature, addition of a screw does take away the joint surface from 6 to 9%. So we may consider applying a plate anteriorly. Uh, in arthritic situation here, we may use anterior plate after the 2 crisscross screws, and this is how we went ahead in this case with 2 screws and anterior plate. So anterior plate does resist the plantar flexion, and it is buttress resisting for dorsiflexion. So plates have been also described by these authors. In our scenario, these plates are not available, but this was a case of deformity with arthritis where we have used the distal radius plate bent and used in this to achieve a good fusion. And this is how she walks. In few of cases, we have used lateral plate also. This was fibula and lateral plate we have used along with the screw. This was tibiocalcaneal fusion. Another case where we have used the lateral plate, which is a anterolateral plate of distal tibia. So definitely anterior or lateral plate augmentation, literature says that it is improved rate of fusion seen in these ankle fusions, and uh, better than the rate of fusion of only with the screws. So to achieve good results of ankle fusion, we need to have proper approach which will give you adequate corridors for preparation of the joint, and which will allow you to position the joint in optimum manner, and then fixation with with screws alone or screws augmented with plate yield a good result. Thank you so much.
Thank you, Sampath. Thank you so much. Our next speaker is Dr. Rajesh Simon. He is MBBS MS Orthopedic. He is fellow of UAB Foot and Ankle Fellowship. He is also done fellowship with AO Expert Foot and Ankle in Australia. He is senior consultant and head division of foot and ankle at Lakeshore Hospital, VPS Lakeshore Hospital, Silverline Hospital and Care Hospital at Kochi, Kerala. He is past president of Indian Foot and Ankle Society in 2022-23, past president of Cochin Orthopedic Society, past honorary secretary of Indian Foot and Ankle Society for between 2016 and 18, and past joint secretary of Kerala Orthopedic Association in 2012 and 13. He is also pioneer in foot and ankle surgery in south of India, and he is doing excellent work in Charco foot surgery in foot and ankle. He is also invited faculty in various international and national meetings, and also he is AO faculty and AO chairman of various courses, and he has many publications to his credit. Over to you, Rajesh.
Thank you, Nikesh, for your kind words. So we all know about the indications of arthritis and the fusions, traumatic, be it rheumatoid, infectious pathology, or osteochondritis. We just saw about the open, it has got extensive soft tissue dissection. There are few patients, especially in rheumatoid patients, having wound healing, and of course there is an increased pain, and there is a prolonged recovery time in these patients. And if you have an open procedure with previous scars, it makes life problem. inflammatory arthritis with all those immunosuppressants are also a problem for an open surgery. So if you look at this particular paper, compared between the arthroscopic arthrodesis and open arthrodesis, and they found that the OT time, the hospital stay, the fusion rates, the fusion time, everything was less than the open fusion. So if you look at further literature, open arthrodesis is often associated with little bit of an arthritis around that joint because of the stiffness compared to the arthroscopic arthrodesis. The indications for arthroscopic arthrodesis, as you know, is grossly arthritic ankle, but less than 15 degrees. So that is something catch if you are planning for an arthroscopic arthrodesis. It should be less than 15 degrees. And if you have a grossly deformed ankle or a large bony defect in the talus or irreducible deformity, then these arthroscopic arthrodesis is not the ideal indications. The goal of surgery, we all know it should be in 5-degree valgus, 5-degree axial rotation, and the dome slightly posterior to the anterior aspect of the tibia. So now we have a patient here, a weight-bearing X-ray, grossly arthritic ankle, less than 15 degrees of problem. And so we anteromedial and anterolateral and the portals. And the scope of 4 mm with large shaver is what we need. And the whole idea is to have the soft tissue preservation, adequate surface preparation, and compression. So compared to open, when you do an arthroscopy, you are picking from an open one, while my video is not working here. So here the whole idea was to show it was seen in an arthroscopic view. And when you're looking at the joint, now you can see the picture, the whole joint is seen. Even the smallest of the cartilages can be removed. So you normally remove from anterior to posterior on the talus and posterior to anterior on the tibia. And then you have the ring curettes to get it complete posterior curettes and chisel up to fenestrate. And this is all can be done in detail by viewing with the scope. And then at last you can reduce it with KYS. How about the construct, 2 screws or 3 screws? We heard few of the cases about some Sampath saying, what about 3 screws or 2 screws? So here I have few papers on the arthroscopic way. The effect of screw positions is better. These people said that with 3 parallel screws from medial to lateral. Another paper said that 2 parallel screws are very good, need of 3 screws. This is a third paper which came, again, a comparative study, and they found that the 3-screw fixation is better in union rate, decreased time of union, increased compression, torque resistance, and improved stability. But then, is that taking off the bone more is the question. This is a review article which came very lately in 2023, and they said that 2 screw is good enough, does not significantly reduce the non-union rate compared to the 3 screws. So the debate of 2 screws and 3 screws is going on, but 2 screws is also good. General dictum, if it is valgus, start from medial to lateral and varus lateral to medial to get the correction, whichever the minimal correction here is. This is another interesting paper that came lately in 2022 saying that the largest sagittal interscrew distance and the tibial width ratio, this is the thing, the ratio, the black arrow is the sagittal ratio and the white arrow is the whole tibial width. So if the width is large between the 2 screws, then the union rate improves. So you have to span, the whole idea is to span the fixation and don't keep the screws close to each other. So again, this initial stability and stress distribution with 3 screws of 3 kinds of 2 screw fixation. So this was a paper which came, how can you put the screws? Is it from parallel or a home run type or a cross type? and they found that two screws that comes from the home run type, that gives the best of the stability. So two home run screws from posterior to anterior, from medial to lateral, this gives the great stability and gets faster union. How to assess? You need to have, as per this paper from Vincent, says that 103 should be the ideal from the long axis of tibia and to the joint axis of the subtalar joint. So this would be an ideal situation for assessing the fusion. So arthroscopic fusion at the end, minimal soft tissue violation, low post-op morbidity, short hospital stay, quicker fusions, and significant lower incidence of other joint arthrodesis. So definitely, if you have a minimal deformity or a non-deformed ankle, then it outperforms compared to open. Our experience, we had few cases. This is a huge osteochondral defect, almost more than 50% of the joint. My MRI couldn't find out, but this is how it was. Wanted one surgery because of the compliance, the finance issue. And this is how we went, and in 6 months' time, complete fusion, absolutely no problem here. This is a post-traumatic case, again, 2 years back. Syndesmosis was not fixed. Arthritic, again, a staff nurse, and didn't have much of choice of money. Very young lady, immediate post-op, and in about 6 months' time, you can see how normally, almost near normal, she walks with a fusion rate. This is another trauma case. Again, 4 years back, she had a trauma, and they had a fusion. And here we use the headless screws with 3 screws construct, and it goes on to heal. So in our experience, a small experience of 23 patients, where we had 2 screws in 16 patients and 7 patients had 3 screws construct, we had only 1 patient who had delayed union with 2 screw construct. All the 3 screws united well, while all the 15 patients of 2 screws also united. So not much of a problem even with 2 screws. Yes, 1 delayed union, and we bone grafted at 10 weeks, and it healed well. So arthroscopic arthrodesis is the gold standard for a non to minimally deformed ankle, and it's time you change the hammer to the scope when you're going about it. Thank you very much.
Rajesh, for a lucid presentation. Our next speaker is Dr. Malhar Dave. So Dr. Malhar Dave is practicing as an orthopedic and foot and ankle surgeon in Vadodara, India since 2000. He has special interest in forefoot reconstruction of deformities, and he has been invited to various meetings, both national and international. He is doing pioneer work in reconstruction of rheumatoid foot and Charcot foot. Over to Malhar. You can share your screen, please. He will be speaking on role of external fixator and Elizarov in ankle arthrodesis.
Good morning and good evening to friends in this part of the world. I'll be talking and we'll be seeing some of the cases which we use for external fixator devices in ankle fusion. Now, the indication for external fixations in ankle arthrodesis are fusions which are not amenable to routine plate screw or arthroscopic approaches, wherein you have a compromised soft tissue envelope, you have a previous history of sepsis, or you have an inadequate bone stock, and where you need to correct the limb length inequality, which is not corrected by shoe wear. You have a prior failed ankle fusion with internal fixation, and the bone stock is not well, or you have a non-compliant patient who would not be agreeing on a limited restricted weight bearing. The advantages of an external fixator would be an attempted salvage before an amputation is advised in case of an infection, or you want to simultaneously correct limb malalignment, or you want to lengthen the limb. You can have an immediate weight bearing with a foot frame, and even if you have a delayed fusion, you can have an additional compression on follow-up visits. The malalignment, if or an inadequate alignment during the intra-op, can be subtly adjusted in the course of union. So what would be the contraindications for an external fixator? And we are mainly talking about the wing external fixator. Is an adjacent total joint near the place of surgery. You have an opposite limb neuropathy because the pins, the patient can injure the opposite limb. Now this, especially the circular wing fixator, has a learning curve, and patient compliance is of paramount importance. Now, if you look at some surgical points, it's the circular wing fixator would mostly consist of a three-wing construct. You have a proximal tibia wing, a middle talar wing, or a midfoot and a hindfoot wing, and it can be a pre-assembled or a constructed stage-wise on table, depending on surgeon training and preferences. Proper joint preparation is of paramount importance of whatever method of fixation you want, either be it arthroscopic, open, or and wing fixator, and you require to do the closure of wound before the application of the frame, and you can delay the weight bearing till the primary wound heals with a proper pin care and pin tag care. Removal of the frame is usually done when the bridging bone is visible in two planes, and then it is protected in a plaster or boot till the tibial pin sides heal. Because if you have an immediate weight bearing with a stiff ankle, the chances of a proximal tibia fracture to the pin side is possible. So the commonest complication of an external fixator would be a pin tag infection and a stress fracture, and very rarely non-union. Now, there are not many large case series in literature wherein there has been comparison between the external fixator and arthroscopic and or open ankle fusions, because probably it is not practical for all patients and surgeons to have these route of fixation in routine ankle fusion. So there's a paper 2019 comparing Elizarov and internal fixation, wherein probably both of them work the similar way. So going to cases, this case courtesy of Sampath. There's a trauma case. Now the commonest presentation what we see are usually either in fresh trauma or neglected trauma with infection, congenital deformities, and neuropathic. So I'll be taking a couple of cases. So this is the first case. 24 years policeman. He had a wound on the anterolateral aspect. He had a loss of talus, and the talus was not brought by the patient. Now this is the X-ray. The talus is absent from the wound. Medially, the wound was not bad, but the talus was absent from the lateral aspect. It was debrided and cleaned in the emergency, and an external fixator, monoframe external fixator, was put in with a Steinman pin across the calcaneum and the tibia, and then a split thickness skin graft was done to cover the wound. And then the patient got the talus after about SARS, 14 hours after the talus, which was then of no use. And then the wounds healed over a period of time. And then after about 2 months, when everything healed up, an anterior approach to the ankle was done. And then bone grafts from the iliac crest were taken. Then they were incorporated within the fusion site. And then additional stability to the forefoot was given with the external fixator. And then it went on to heal. And this is the final outcome with a plantigrade foot. This is a second case, a 52-year-old female diabetic with peripheral neuropathy, and who presented innocuously with pain and swelling around the ankle, which was treated with analgesics and brace. But she progressed rapidly under treatment, observation, and she collapsed at her ankle, and then was managed. This is how she then later on presented with extreme amount of abduction and wound over the lateral aspect. And then she was managed in a circular wing fixator after thorough debridement and a tibio-talar fusion with the calcaneum part of the talus which was there. It was fused to maintain the alignment. And then this is after the frame removal at 9 months. This is what she had. She had a nice alignment and a good plantigrade foot to walk on. A third case is congenital deformities since childhood. This is how she was walking. She was now of a marriageable age and wanted some correction to her feet. And so these are the X-rays which shows probably a neglected club feet, and then the open procedure in the form of lengthening of the tendo Achilles was done, and then a lateral approach was taken, fibula was moved, talectomy was done, and then post talectomy she was then the reduction was done, and an external fixator was applied. The wound over the posterior aspects then treated with a split thickness skin graft, and then she was maintained on this external fixator along with Steinman pin till union. As you can see, she progressed nicely to union, and then everything healed up over a period of time, and she had a plantigrade foot with an fusion of the tibia and the calcaneal surfaces, and then she had a plantigrade foot to walk on. So this is not necessarily using the circular fixator, but also with a monoframe fixator this was used. Again, a case of open trauma, which is very common, the vehicular accidents. This was an avascular fragment which was removed from the lower ankle side. Proximal corticotomy was done to address the gap. And then over a period of time, bone transport was done to fuse the tibia with the talus, the remaining tibia with the talus with proximal length, and frame removal was done at 7 months. Another case with an open tibia which was treated elsewhere with an hybrid sort of a fixation, and it had exposed bone with pus discharge, and then in the initial period the frame removal was done. About 8 years gap of the distal tibia was done, and then a gradual bone transport with corticotomy was done, and the tibia was fixed to the fused to the denuded talus over a period of time. And then at about 9 months, there was a hypertrophic regenerate. Patient wanted frame removal, so the frame removal was done, but then was protected with a PTB cast, and was then given a plate because of a weak callus at the proximal corticotomy site to protect the regenerate, and then went on to heal nicely. Thank you.
So Dr. Rahul is MBBS, DNB Orth, Diploma of CCOT and Fellowship Foot and Ankle Reconstruction. He is Director-in-Chief of Foot and Ankle Injury Center at RHL, Jaipur. He is founder of Jaipur Foot and Ankle Society, member of IFAS Executive Committee, member of CCOT Executive Committee, member of Rajasthan State Orthopaedic Surgeons Executive Committee. And he is also course chair of CCOT IFAS Collaborative Meet, CIFA, which happened in Jaipur. And also is member of Board of Examination of CCOT and Fellowship Coordinator of IFAS. He will be speaking on tibio-talocalcaneal fusion, TTC fusion. Over to Rahul.
Thank you, Nikesh. So after these lovely lectures, we'll be talking about one of the most maximally invasive procedure that we are doing for the ankle fusion. So my screen is visible and in full mode, right?
Yes,
right.
Go ahead.
So we'll be talking about the tibio-talocalcaneal fusion using the TTC nail. Now, why we are talking about this in particular, apart from the ankle fusion, because the indications are a bit different, but the ankle itself acts as quite a different joint from others. So we see the contact area of ankle is quite low, but the stress is quite high. But still we see that the primary osteoarthritis in ankle is not as common as it is in other joints. And what could be the reason? The reason is it is one of the most congruent joint, which has a perfect matching of the tibio-talar joint surface, and it does not allow the contact stress to concentrate and cause a primary OA. So we have seen that the most of the osteoarthritis in ankle is primarily a post-traumatic osteoarthritis. And because, as we talked, it is a highly congruent joint, so there is a uniform distribution of load. So we'll see this case progressively throughout this presentation, which is on the screen, about a post-traumatic. The ankle fixation was done, which which gradually progress to an ankle arthritis, and slowly over the time it also progressed to the a hind foot arthritis rather than an ankle arthritis. And why it is important is because we have seen over the study, there are multiple studies which have shown that the slight shift of the joint surface, slight incongruity of the joint causes a double loading of the ankle, nearly 40% decline in the contact area. So if we see current literature, we have seen that nearly 70% of the total arthritis of the ankle is a post-traumatic arthritis and not a primary osteoarthritis. Could be a result of a rotational fracture, could be a result of the ankle instability or a continuous ankle sprains. But what is also important to understand is because of these, sometimes the conditions, they progress beyond ankle. Now, ankle is also different because there are multiple other adjacent joints which are there to share that load. And sometimes when the ankle fails, as a result, these subsequent joints, especially the subtalar joint, also fails. So these are those conditions when we see that the conditions has progressed beyond ankle. Now it is a hind foot complex arthritis, which may be ankle plus subtalar, which could be a post-traumatic talus avian leading to a subtalar arthritis, sometimes a Charcot arthropathy, sometimes a non-union of ankle arthritis, gradually resulting in this condition. So this is, again, a post-traumatic or subtalar arthritis, rheumatoid arthritis. So common indications are these post-traumatic Charcot deformities, stage 4 posterior tibial tendon dysfunction, avian of the talus, a failed total ankle, a failed ankle fusion, loss of the talus, any of the failed hindfoot deformities which has been there. The goal and the fixation options using a TTC method is, again, to have a solid pain-free arthrodesis and a biomechanically stable and a functional positions. Now we can do this TTC arthrodesis using screws, using plates, external fixators, and the intramedullary nails. And we'll be talking about one of my favorite devices, which is an intramedullary nail, because especially in India, we get a lot of these complex ankles, a lot of these neglected ankles with huge deformity. And this device works as a magic on all these cases. It provides a load sharing device. It has a superior biomechanical property, and it's an excellent choice in case of a TTC arthrodesis. It is stiffer than a cross-leg screws in bending and torsional directions. So it is better to maintain the alignment of the hind foot during union, and it may increase fusion rates through increased stability of the internal fixation. So multiple papers have done studies over and the comparative studies of TTC with screws and plates, and they have found that the biomechanical superiority of this device, the TTC nail, is proven beyond points. So what are the common tips and tricks that we have to take care when we are using this TTC nail as a fusion choice? So we have to plan our incision. Now there are various methods. I'll be talking about the lateral approach, which is what I do. But then again, there are posterior approaches to do it. And then again, there is an arthroscopic approach to do a TTC nail also, when there is not gross deformity, when there is absolute straightforward hindfoot arthritis. Now these cases are not so common to see. We see very commonly deformed and malaligned ankles resulting in such deformities or hindfoot deformities. So the open approach is far more commoner than an arthroscopic approach. So we'll be talking about the lateral approach, where we take a direct lateral. We do a transfibular osteotomy 2 to 3 centimeter above the lateral malleolus. We try to cut fibula in a beveled fashion. We avoid injury to the cutaneous nerves and make sure there is no undue tension over the skin while we are trying to raise the flaps, while we are trying to retract the skins. And meticulous joint preparation is the key. Now, very important to remember is it is not just the ankle joint, but also the subtalar joint that has to be prepared. So while we are making our lateral approach, our skin incision should also incorporate the access to the subtalar joint so that we are able to access this joint. We can open up this joint either using a laminar spreader or using a KY distractor, both of which give an excellent exposure to the entire joint. And while we are doing this joint preparation, we have to make sure that we are going all the way up to the medial aspect, up to the medial malleolus, and preparing the joint of the ankle and the subtalar joint. Then once we have prepared the joint, we are able to realign the entire hindfoot. And we are able to make sure under the C-arm, under the IITV, that we have achieved the correct alignment. We go ahead, we can do a temporary fixation using a first K-wire, which is across the hindfoot. And then we start doing our entry guide wire. Now, idea is to have a neutral dorsiflexion or plantarflexion. We have a 5 degree of varus or valgus. Rotation equal or slightly more externally rotated, and anterior aspect of the talodome is brought to anterior aspect of the tibia. So it is also very important to understand that while we are trying to take an entry or make an entry using a guide wire, so our guide wire should not be going more posteriorly over the tibia, otherwise it is going to push it further and the patient will come up with a midfoot pain later on. What is the entry point? Now the entry point is that we make a line in a sagittal plane from tip of second toe to the center of the heel. It can be drawn in a coronal plane, which is a bisector line which connects both the malleoli, and this is where we start to insert. The ideal position of this entry is about 2 centimeter posterior to the articulation of calcaneus with the transverse tarsal joint, and it is anterior to the weight-bearing surface of the calcaneus tuberosity. So our idea is, one, we do not destroy or we do not damage the nearby joints. Second, we have enough space for the distal locking screw to have a purchase inside the calcaneus. At least 1 to 1.5 centimeter of purchase is ideal to have. What are the structures at risk? It is a flexor deuterum brevis, a plantar aponeurosis. We can have lateral plantar neurovascular bundle which can be injured, or a medial neurovascular bundle which can be injured, and that has to be taken care of. Now we do it in a supine position. We can place the foot over a bundle of sheets or a boulder, which gives us more access to the lateral all the way up to the posterior aspect. Lateral approach all the way up to the subtalar joint so that we can access both the joints, ankle and subtalar, to the same incision. We do a fibular osteotomy. I would like to have my C-arm placed so that the initial X-ray is also visible along with my new C-arm images, so that I can compare every time I need to correct things. Once I have done a fibular osteotomy, there are 2 ways. If it's a young patient and you think that you might convert this into ankle replacement, sometimes later, once everything is healed up, you have to preserve the fibula. Otherwise, you can do a fibular osteotomy, take off the fibula and use that fibula as a bone graft in cases of a large deformity or large bone gaps. So once you have done that, you can use this K-wire distractor to access both the joints, both ankle and subtalar joints. Once you've done that, this is how we make an entry. Guide wire, and finally a nail is placed after the reaming has been done, like a standard reaming to be done in tibia fractures. And then we do the proximal and the distal lockings. Now there are nails which have their own compression modes, the fixation modes, which can be used to achieve more compression across the ankle and the subtalar joints. And a third cross leg screw is also, it improves dramatically the overall stiffness over the locked retrograde IM nail. And it has been proven in this paper in 2005, and we have started using this and it gives a brilliant results. Post-operatively, it can be immobilized in non-weight-bearing cast for 6 weeks, followed by 6 weeks in air cast boot. And this prolonged immobilization is usually needed in bones which are osteoporotic, which had a large degree of malalignment and bone loss, or a Charcot arthropathy. But sometimes when it was a plain hindfoot arthritis with good bone stock, rather we can have the quick mobilization of full weight bearing even immediate post-operative day. Now we have a new generation nails coming up, which, already in the market, which have 10 degrees of the posterior and the lateral bands. And again, in India, not so many of nails are available. The synthesized nail, but the problem is you have to do that in a prone position rather than the supine position. So it is up to the choice of the surgeon in what particular position they want to do it, and use their nail as per that. But the idea of having these bands is that because in a frontal view, the tibial axis is far medial to the posterior process of calcaneus. So having this band, about 10 degrees of this lateral band, gives you more access through the calcaneus body, which is more access throughout the solid bone, and less chances of a medial blowout, because the entry point is the most important mark. Sometimes if you're too medial while you're trying to enter inside, so that you have a good central purchase into the tibia, it is too medial, and while reaming or while putting the nail, sometimes the medial wall, it breaks and there is a medial blowout and nail comes out to the medial, and there is failure of the device. So that's why these posterior and the lateral band nails help you to achieve that. Now we have options of dynamic proximal locking. We have longer nails so that there is reduced chances of stress fractures. So now what is better? Now people say that ankle arthrodesis gives a near normal results and TTC arthrodesis is much more stiffer because of the subtalar involvement. But lot of studies have been done, and they have shown that both of them give a considerable good outcome, because most of the patients with ankle arthrodesis, they have a higher post-operative expectations of their activity, and when they are less likely to meet them, they're not very happy. That might be the only reason that they are comparable to the TTC. But we have seen that the fusion rate is very high. We have 93% union rates in the study of 59 nails which was done. 84% had excellent to good functional results. But again, like in every other surgery, things can go wrong. There could be a metalwork problem, the implant failures, there could be deep infections, delayed wound healing, especially in Charcot arthropathy. So what are those conditions when these go wrong? They can go wrong in smokers, where poor soft tissue is already there. When there is a peripheral vascular disease, history of open trauma infection, elderly individuals. And the answer to that has already been given by Dr. Rajesh Simon in terms of arthroscopic approach to such fusions, or using an external fixator as explained by Dr. Mallar the way. But all these options have to be taken care of when we are trying to use this, and make sure that you use these open mini open techniques or the arthroscopic techniques as much as bone graft and minimal stress over the skin to avoid these the skin or the wound problems. So the take-home messages, they provide superior biomechanical properties and an excellent choice for TTC arthrodesis. It's more of a salvage procedure in case of severe arthritis, where both ankle and the subtalar joints are involved, along with the hindfoot deformity. Selection of the patients, good joint preparation, stable fixation. That is the way to go to avoid the complications of these. And we have to give a good preoperative counseling, because we have to explain these patients what are the expectations, the practical expectations they should have, and what are the limitations after the surgery that these patients will be facing. Thank you.
Thank you, Rahul. Thank you for a beautiful presentation on such a complex ailment. So now all presentations are done. So we'll discuss each and every point in detail. We'll get the panelist view on many controversial topics or many topics which needs attention and the final say. I will share my screen for discussion. So regarding the first discussion topic is approach. So as everybody knows, the arthroscopic procedure has the high union rate compared to the open approach. But at the same time, the caveat is it is reserved for the patients with little or no joint deformity, which is less than 15% in varus or valgus. So that makes the patient profile less complicated than what we get in the open approach, wherein the union rate is obviously low because of the maybe the patient profile is different than the arthroscopic approach because of the more deformity, severe disease. So open approach is utilized for the patients with moderate to severe deformity, but it also gives us the better visualization of the malalignment correction. And there is also ease of applying implants like plates and screws. And if bone graft is needed, we can easily apply the bone graft. And but on the same manner, there is high rate of wound complications, and there is longer hospitalization and the recovery time. So I would like to know from Dr. Rajesh, what is your take on this? As per my opinion, arthroscopic procedure is reserved for mild deformities, and which can be a factor of their high union rate than the open approach, which is done for the more severe variety of cases. Is there any bias, and what are your personal tips on getting the successful arthroscopic fusion? Dr. Rajesh, please.
Yeah, thank you, Nikesh. I mean, I shared in my presentation about the various screw combination, which would probably be better. 2 screws, 3 screws, little more wider. Home run screws are better. Now, as far as the union rate is concerned, I think 95% to 97%, some people presentation papers have presented 97% percentage of healing. So I think arthroscopic arthrodesis is much better compared to the open. But yes, we should know that 15-degree is the thing. How can we go beyond 15-degree? Maybe a mini open technique and open up the joint to correct it. We can do it. but then grossly deformed like what we see in India may not be possible in an arthroscopic control. We have been doing, I mean, I just presented about our 25 cases, where 24 patients actually, and it was all either post-traumatic minimal deformity or just an arthritis because of rheumatoid arthritis and all that. So it was not beyond 15 degree. And I do agree, when it is beyond 15 degree, you have to open, but then it also comes with all other problems. Screw wise, I think two screws, as far as our own personal way, two screws have worked very well. Only thing is, you need to have one home run screw to get that real compression, and the second home run screw, if possible, wonderful. Otherwise, two screws, if at all three screws, fine, but two screws is good enough. Headless screw versus with head, I think both have functioned. I felt head screws gave a little more compression when I am doing it because of that the head impact. But yes, people do have the screw head issues at times, the thin patients. So I prefer thin patients using headless screws.
Thank you so much. So next comes the approach in the open surgery. So definitely NT approach gives us the better visualization. Surgeons are also more familiar with this approach. There is also cartilage removal is easy, and also we can assess the correction of the deformity easily, and there is also facilitation of accurate placement of the internal fixation. The anterior border of the tibia is also wider, so that proper placement of plates and screws is easily applicable. It also preserves the fibula, so thus does not compromise future conversion to arthroplasty if required. But on the other hand, it puts the superficial peroneal nerve and the anterior neurovascular bundle at great risk. Regarding the transfibular approach, which provides good view of the anterior and posterior joint surfaces, and it also is less threatening to the neurovascular structures, but it comes with the benefit of free autologous fibular graft material. And union rate is almost similar in both anterior and lateral transfibular approach. I would like to know from Dr. Malhar, what is your preferred approach and how do you approach the ankle arthrodesis? Any tips for and take home message for the attendees?
Yeah, so for the patients who might have a later date ankle a replacement to be converted because of paucity of implants or financial restrictions as of now, I opt for the anterior approach, and the other patients I usually go for the lateral approach. And usually when I use the anterior approach, I use the plate. So when I'm thinking of using the plate, I use the anterior approach, and for the three screws, I use the transfibular approach. So this has been my way of looking at things for ankle fusion.
Thank you so much.
Uh,
So now
there seems
comes,
to be there seems to be a question on the chat.
okay, let me check once I'm done with this.
Okay.
Can you read the question? Because
Yeah.
I'm on the.
It's a question from Kaj Kaule. How do you shorten the fibula if you fuse the joint by arthroscopy and correspondingly shorten the tibiotalar space?
Okay,
And
Dr.
the
Rajesh
second
can
question,
answer.
the second question was, who fuses the ankle joint to the posterolateral approach?
Rajesh, can you answer the
Yeah,
arthroscopic question?
I mean, when you're doing an arthroscopic, you really do not osteotomize the fibula. You just shave off the fibula, lateral gutter, the medial gutter, but you really do not do a fibula shortening. We do not osteotomize the fibula, except for if you are trying to correct the deformity. So that is something where we can shorten the fibula to correct the deformity. But for correction of the the breaking the fibula, you can either use an MIS if you have, or a small saw if you want to, but you cannot do it otherwise with a scope. So that is a separate approach altogether. But most of the time when you're doing a scopic, we don't touch fibula at all. And I don't do anything in from scopically in the posterolateral It is more of a translateral in the open way. I think the open people can answer on that.
Okay.
Yeah,
Sure.
a follow-up question, Rajesh, on that is then the fibula seems to be long, is which I don't think happens because you are cutting very minimal amount, or you're just denuding the articular surface, so it does not as such shorten the tibia as much to have a significant effect.
Yes.
Yes.
So
Yes.
I normally don't use too much of burr. I use curettes and little bit of a burr to end up the last this thing. If you use too much of burr, then only the shortening happens. But otherwise, you generally don't have a shortening of tibia.
I think regarding the posterolateral, I think Sampath could talk if he has any experience in the posterolateral open approach.
No, I mean, I have also not taken posterolateral approach to be specific. Transfibular approach we have taken, but not the posterolateral.
Okay, great. So we'll go further. So there is also consensus regarding the flat cut or the maintain the congruent natural shape. Maintaining the original articular congruency confers inherent stability with excellent opposition of bleeding bone surfaces. And of course, the joint alignment as told by all the speakers. And also we should avoid the use of power instruments to remove the cartilage to prevent the thermal necrosis. Dr. Rahul, can you throw some light on how you prepare the joint? What are your tips and uh, any take home message for removal of cartilage?
Yes. So again, when we are trying to approach these joints, one is to have, first and foremost, to have a very good exposure to the entire joint surface. So until unless we have a good exposure to the joint surface, it is not going to be easy, and we end up, digging up more inside the subchondral bone and making up a hollow surface there. So the basic idea is to have a good exposure. Now we can use either a laminar spreader or we can use a K-wire distractor to expose our joint as much as possible. And while we are trying to do that, make sure that we have 2 mm K-wire at least to distract the joints. Otherwise, the wire, it gets bent and you don't get an adequate exposure to this.
Oh,
Once you have exposed the joints using these devices, either a K-wire distractor or a laminar spreader, either we use a 5 mm curved osteotome to do that, or you can use the cartilage peeler to prepare your joint surface when there is no deformity. Now, when we are doing a TTC, especially like I talked about, there is usually a malalignment which has either a varus or a valgus deformity. You will see that the articular surface of the tibia or the talus will not be as a normal curved articular surface. It would be a flat. Sometimes one side, medial or the lateral side, would have some amount of bone loss. And in that case, you usually can use a wider osteotome and make a straight cut over both the surface and prepare the joints. But the basic idea is to have a good bleeding surface of the bones.
thank you.
All right,
Thank you so much.
guys. Fantastic
Thank you.
session. Got a lot of great questions and a lot of great comments. Thank you so much. We got to wrap up so that we can get ready for the next session.